Good afternoon, class, and welcome to our argumentative presentation claiming that mechanical valves, while currently limited by current technology applications, are superior to bioprosthetic valves. In order to quantify this, we have pulled from a variety of credible sources such as the U.S. National Laboratory of Medicine and the National Center of Biotechnology Information. We shall later discuss the potential technologies that could be used to improve the functionality of mechanical valves, which we have learned from this coursework at Clemson University.
Currently, there exists a risk model associated with the potential failures stemming from each form of valve replacement. This risk model is taken from the U.S. National Laboratory of Medicine, and it serves as a medical guideline for which form of valve would be best suited to ensure the patient runs minimal risk of complications. The only quantitative dependence of this function is based upon the patient age, which is loosely indicative of overall heart health. Ideally, this relation would be based on much more concrete information, such as the contractility of the heart or other defining parameters. However, the generalization is drawn for cases in which the valve replacement is urgently needed and no other quantitative data could be collected.
According to the European Society of Cardiology, there are several factors that indicate the use of a mechanical valve over a bioprosthetic heart valve. The first factor is age. Research has shown that if a patient is younger than 60 years old, then the mechanical valve has better success over the bioprosthetic valve. The second factor is the patient's preference for avoidance of reintervention versus avoidance of anticoagulation. Anticoagulation can be monitored and corrected with medicines such as warfarin, but the bioprosthetic valve has a much higher chance of needing replacement during the patient's lifetime than a mechanical valve. This is why bioprosthetic valves are recommended for patients over 60 years old, while mechanical valves are recommended otherwise, with a regimen of anticoagulants supplementing the heart valve replacement.
The need to use bioprosthetic valves is largely due to bleeding issues in older patients that are not as receptive to anticoagulation treatments. Essentially, the issue resides in the mechanical structure of synthetic heart valves not being optimized to function properly in hearts that exhibit lower contractilities, and the blood flowing through the valve is not properly regulated, causing backflow and life-threatening pressure differentials within the heart itself. With the current technology available to us, it is in fact safer to apply the use of bioprosthetic valves to older patients. However, that is not to say that will always be the case. The fundamental argument we are attempting to make is that mechanical valves could be advanced so as to outperform bioprosthetic valves in the very near future. With modern breakthroughs in micro and nano fabrication, it is entirely possible that a chip could be designed so as to recognize the electrical signals sent through muscle tissue and react accordingly to ensure the valve functions as intended.
Intensive coursework within the realm of micro-nano fabrication has enlightened us to the possibilities of integrating MEMS technology with ICs to generate a more viable mechanical heart valve that will better react to patient needs. Through the use of electrodeposition on microchips, they can be calibrated to recognize differences in electrical potential, which we have learned is the means by which heart contraction is communicated throughout the vital blood pump. As chips have consistently gotten smaller and more complex transistor paths are designed, it is not infeasible that a chip designed using advanced EUV lithography, which can achieve a resolution of 7 nanometers, could be integrated into a heart valve to accurately track contraction and use that information to regulate blood flow more accurately without dependence on chamber pressure, which is unreliable in older patients.
After taking into consideration a patient's age, their risk factors, the potential for bleeding, and the current technology of both mechanical and bioprosthetic heart valves, it has been determined that mechanical valves are superior to bioprosthetic valves. Mechanical valves pose the lowest risk of reintervention, and their associated anticoagulation problems with mechanical valves can easily be corrected with anticoagulants like warfarin.
As technology advances, mechanical valves will become infinitely superior to bioprosthetic valves, even in older patients, as the bioprosthetic valves cannot be advanced past the limits of their biological host. Mechanical valves always have the potential to advance to the needs of specific individuals, whereas bioprosthetic valves will continue to look the same for the foreseeable future.